Good
Good evening,
evening.
Lakshman sir.
Good evening. Good evening, ladies and gentlemen. Welcome to this journal club. What Pavan has chosen is an interesting topic. Chronic abdominal pain is a very common condition that we see, and I'm sure most of you would have read the paper that has come. And the investigators have looked at the role of PET-CT as an adjunct to what they call routine testing. And the paper has a lot of points that one can discuss about, and that makes it an interesting paper as far as the journal club is concerned. Over to you, Pavan, to give the presentation. Thank you.
Thank you, sir. Good evening to everyone. Today, this month's journal club topic. I am Dr. Pavan from Sagar Hospital, first year DND resident. Sir. Sorry, sir. Sir, can I hear you, sir?
We can hear you. We can see. Please go ahead.
Yes, sir. This month general topic article on general topic is that utility of metabolic imaging in patients with obscure abdominal pain. It is published by it is conducted by Vitish et al. It is a prospective study done in published in Indian Journal of Surgery and published on 15th March 2020. The study conducted at Tertiary Care Center. As we know that pain is the common complaint which the patient coming to OPD and all. It is considered as the fifth vital sign. It is more complex and difficult to assess. And abdominal pain is the third most common complaint, and 25% of the adult population has abdominal pain associated with or without gastrointestinal discomfort. And patients coming to the OPD are who are having undiagnosed abdominal pain, undergoing a number of investigations, but still they are dissatisfied. And which is then the pain abdomen is a challenging complaint for both physician and as surgeon. And diagnosis of a pain abdomen, diagnosis of functional disorder in elderly patient should be cautioned. Mostly it may be some organic disease. Glucose metabolic imaging with FDG PETs detects infection, inflammation, and malignancies earlier than the structural imaging. It helps to assess the undiagnosed pain abdomen. PET-CT is very sensitive in picking up the inflammatory, infective, and neoplastic foci which are missed in the ultrasound and CT scan. The aim of this study is to use of utility of the FDG PET scan in undiagnosed pain abdomen. Hypothesis is the PET scan shall pick up ongoing inflammatory changes which does not cause any anatomic distortion which may be missed on CT scan. This study is conducted in the Tertiary Care Hospital from December 2016 to July 2018, and 30 patients are recruited in this study. Those patients who are coming to general surgery department and casualty and wards. And ethical clearance from the institute and informed consent are taken from the participants. The protocol of this study is the FDG PET acquisition was done 60 minutes after the injection of 10 mc of 18-fluorodeoxyglucose. The scan was done from the level of orbit till mid-thigh, and CT was done for attenuation correction and anatomical localization. The scanners were used either Biograph or Discovery 710. Patients more than 18 years of age, at least either ultrasound abdomen or CT scan, CECT is normal, and those who having no findings in clinical history and examination with the routine normal laboratory findings, and no findings on ultrasound and CT scan are included in this study. And those patients which are coming to emergency surgeries are hemodynamically unstable patients, and medical disorders or malignancies, and pregnancy and lactating patients, and those common medical causes included but not limited to gastric, inflammatory bowel disease and hepatitis are excluded from this criteria. And the reports, the FDG PET reports are analyzed by the nuclear medicine physician having more than 10 years of experience, and any abnormal foci or pattern found on PET CT are correlated with the other investigations. If it is clinically significant, and the patient undergo diagnostic laparoscopy to find out a definitive diagnosis and give an appropriate treatment. The results were analyzed in IBM SPSS Statistic version 20 and Microsoft Excel 2016 using t-test and chi-square test. Sir, your voice is not audible, sir.
Yeah, sorry. Before we go to the critique, we will come down to some basics of questions. Dr. Noli asks, what are the cardinal vital signs? Pavan.
Sir, temperature, pulse rate, BP, and
respiration.
Respiratory rate.
Respiratory rate.
All right. So pain is a fifth vital one.
Yes, sir.
Dr. Ramakrishna asks, if an investigation is very sensitive, is it an advantage or a disadvantage in screening?
Sir, whether it is a positive, whether it is more specificity or sensitivity, we have to know, sir.
This question is simple. He doesn't talk about specificity. You're doing a screening test.
Yes, sir.
And that test is very, very sensitive. Is
Yes,
it good for screening or not good for screening?
It's good for screening, sir.
Yeah. Any other votes? What would the others say? Saurav?
Sir, I would feel that it will increase the chances of false positive rate, sir.
Yes, that's one way of looking at it.
Yes, sir.
Anything else? Indraja?
Sir, no, sir.
Yeah, my own vote is that very sensitive test is not good for screening because you'll spend a lot of money doing unnecessary further operations or testing. What is your view, Ramakrishna?
Yes, sir. What you said is correct. It is the disadvantage actually for screening.
Yeah. Okay. So, in fact, he has asked a question which I had in mind. When you see a patient with chronic abdominal pain, and this cohort is one such group of 30 patients, he mentions, the authors mention some characteristics of the PET scan. What are those characteristics, Pavan? They mentioned that it picks up things before anatomical
Before any
changes are
structural
there.
changes, and before any
Correct.
structural changes.
Correct. And what are the things that it picks up?
Sir, any inflammatory changes or infective or
Yeah.
malignancy foci.
Yes,
it can be
neoplastic.
picked
So
up.
it picks up everything.
Yes, sir.
Is that good or bad for you?
It's good only, sir.
Yeah. I mean, it may be good in terms of getting some pathology,
Yes, sir.
but if your focus is on ruling out malignancy, then it is a
Then it
problem.
is-
Then it's a problem. Even
sir.
inflammatory lesions come as hotspots. And if it misleads you to be a malignant condition, you may intervene, whereas an inflammatory lesion, you may perhaps manage conservatively. So using a PET CT as a screening tool or as a diagnostic tool to start with is a double-edged sword. Ravi, you have any comments?
I agree with you, sir. I think the main thing is because they are very clearly set out that they are looking for abdominal pain. I think that probably and because it's one of the first pilot studies, maybe there is some merit in the paper and the merit in the way they have done the test. But I agree with you. If you are doing PET CT as a screening test for malignancy, then you are more likely to go on a what do you call that, wild goose chase.
So in terms of materials and methods, can I have your critique, please, including the introduction, topic, and the work? Saurav, we'll start with you.
Sir, I would say that it is a fairly recent study from a reputed. It is from Indian Journal of Surgery, and they have very well described the patient population.
Yeah.
And the PET CT scan was read by only one single observer. There was no variability, and he had experience around 10 years.
10 years experience, correct.
And
what are the negative points according to you? Vanita. Are you there, Vanita?
The impact factor of the journal is lesser Indian as far as actually in introduction and materials and methods, if we see, sir.
No, impact factor is low. Okay, I agree, but it is our journal, so I have a bias towards our journal. Okay. Yes, what else? What are the negative aspects? Hari.
Sir, I think one point made by Pavan, an exclusion criteria, like some medical causes they have excluded. So it could be better if they explained how they excluded.
Excellent.
Yes,
all right.
So that was not clear.
Very
and
good.
Otherwise, being FDG, the PET scan is a costlier scan.
Yes.
So that I think to take as a pilot study is okay, but otherwise it can be taken as
availability and cost are both factors in the design of the study itself. When you start off, correct? Yes, that's one of the negative things. Yes.
Yes, that's all I could make, sir.
Yeah. How they have? I need you to think a little. You're thinking in the right direction, but look at yourself seeing a patient with chronic abdominal pain. You know what tests they have done: the routine blood tests, the ultrasound, and CT scan. Okay, what else would you do before you think of
a PET CT? They can do an endoscopy, sir.
Yeah, I mean, even before endoscopy, what would you think of? Fecal occult blood.
Urine stool test. Yes, sir.
Fecal occult blood. You know, you're looking at a GI lesion that can give you pain. Fecal occult blood. You would consider both upper and lower GI endoscopy. And if you look at a gastroenterologist's point of view, what is the commonest attendance in a patient, in a GE clinic across the world?
Bleeding PR.
Bleeding PR. That's a surgical clinic. I'm talking about a GE clinic.
Abdominal pain, sir. Gastritis.
I know. What else? Yeah. What is the diagnosis in a GE clinic? If you look at the series of GE outputs, papers, what would be the common?
Disease.
In fact, it's IBS.
IBS.
Actually, IBS. 60% of cases attending a GE clinic have IBS, and in the whole paper, these people never talk about IBS. They have one line which says we must consider inflammatory bowel disease and functional bowel disorders. That's a huge umbrella, the functional bowel disorder. And when you're looking at a PET CT, they also mentioned that they have asked a physician to see the patient, but they must have given a list of tests that the physician did. If these people didn't do themselves, they should have clearly specified the tests that the physician did before there was a joint decision between the physician and these investigators to do a PET CT. To my mind, that's a big deficiency. Nuli sir, any other negative points?
Sir, can I say one more point, sir?
Yes.
Sir, they had told that they had taken patients with pain, but they in their entire protocol they did not mention what was the cutoff value for their pain and how.
No, they have
how
said
long?
4.
They have said 4. They did a VAS score and 4 and above. Yeah.
They have said 4 and
VAS
above.
score was done, sir.
Okay, okay, sir.
Sir, but can I just make a point?
Please.
See, as a surgeon, thinking as a surgeon, if somebody you are evaluating patient for chronic abdominal pain, beyond all the investigations, which I think they have said they have ruled out hepatitis and other things, but I agree that they should have also thought about irritable bowel and treated that and seen whether that those patients were treated for a significant period of time before they were considered chronic abdominal pain. That is definitely a deficiency. But once they come under the surgical umbrella, after all these things, the next thing we have to offer is a diagnostic laparoscopy, which obviously has anesthetic risks and surgical risks. So maybe, offsetting that against the cost of a PET CT may not be such a bad thing.
Correct. I mean, definitely they were looking at it as an alternative to a laparoscopy, but we are looking at this point in time, what is it that would make you ask for a PET CT? As a clinician looking at chronic abdominal pain, that again brings me to a basic question. In the materials and methods, please note my words, in the materials and methods, have they defined chronic abdominal pain? Pavan?
Actually, in results, they...
No, I told you, mark my words. In the materials and methods section, have they defined chronic abdominal pain?
No, sir, they're not defined that.
That is a deficiency. Understand that. I agree in the results, the minimum that they have seen is 4 months, which fits in with a definite generally accepted chronic abdominal pain of 3 months. I mean, generally accepted period of 3 months to call it chronic abdominal pain. Okay. So it fits in, but they should have defined it in the materials and methods section. We talked about IBS, we talked about FOB and the other endoscopy that has to be done. There is another class of things which they should have definitely ruled out before looking at PET CT and diagnostic laparoscopy. Another broad category of diseases causing abdominal pain. What would that be? Indraja, can you think of it? It's a little hard for you. We'll ask Nishant. Nishant, would you think of some other class of abdominal pain which you would think of before you go for something costly like PET or something invasive and costly like diagnostic laparoscopy?
Sorry, sir, I couldn't get the question.
If you're looking at investigation of chronic abdominal pain, okay, and you've done the routine workup of bloods, ultrasound, CT, endoscopy, there's nothing there. And you now have to decide whether you want to ask for a PET CT or a diagnostic laparoscopy. Before you do that, would you look at any other broad class of conditions that can give you chronic abdominal pain?
No, sir, I can't.
Right.
Hypercalcemia.
I'll give you it's called medical conditions that can give you chronic abdominal pain. What are
Hypercalcemia, porphyria.
Yes, exactly. Plumbism, all right, and platelet disorders. If you have ITP, for example, and many syndromes associated with it, they get chronic abdominal pain because they get little bleeds in the wall of the intestine because of fragile and or hypo-functioning platelets. So you have to look at those before you actually look at anatomical or surgical causes. Okay, and that is something which they have not mentioned at all. Ramakrishna sir, you want to add anything?
Sir, and also worm infestations. They have not mentioned how many of them have received the worm.
Correct. That's the first thing we do in the clinic. Yeah. Ramakrishna sir, you have anything to add?
Yes, sir. The first thing is I was just looking at the title.
Yeah.
Usually this type of questions, it is better to avoid in title. That's what I feel.
Yes.
I don't know, others may differ in that.
Yeah.
The other thing in materials and methods, the inclusion criteria is not very rigid. Somewhere they have defined chronic abdominal pain as 6 months. I read somewhere, I don't know. I have to go through the article again. Somewhere I read it.
Yeah, okay.
They mentioned it.
Yeah.
The group of people they have taken is very heterogeneous. As you have already mentioned, day in, day out, if you are seeing at the practice, those patients who have got pain of more than 4 months, we get plenty of them. And it is very difficult to advise this PET CT for all those patients. That is the group of patients is very heterogeneous. That is one thing. One thing. And another thing, what I was strikingly missing is who has paid for this PET scan, whether it is the patient
Obviously,
or the hospital, because that comes under ethics. Now, if it is a experimental procedure or experimental investigation, they are doing a pilot study.
Yeah.
Patient should not be made to pay for this. That part is missing totally in this materials and method. They have not mentioned who has financed it. Yeah. That is a
no, yeah, very valid point, but I presume that the patient would have paid for it. And
then it is wrong,
in that hospital, you know, they would say it is a part of a protocol. It's a part of a protocol to investigate. And they would justify with the reason that Ravi Shankar mentioned, that if I don't do a PET CT, I'll probably do a diagnostic laparoscopy, which is more expensive and more invasive than a PET CT. With that thing, they would have made the patient pay for it.
For that, evidence-based medicine should support it, sir. Yeah, for this type of patient, whether the evidence supports the PET CT in these patients, in this type of group of patients.
Yeah.
Even EBM doesn't permit, then it becomes questionable, and the ethics committee should have looked into this problem.
Because I agree. Obviously, the ethics committee has not bothered about the cost part of it. Before we before you show, sorry, go on.
No, but I think it was done in AIMS. Probably they would have done it for free.
Oh, was it in AIMS? I didn't notice the particular. Then it must be okay.
Yes. That is right, sir. But they should mention in the materials and methods. That's the point. That's all. Yeah. When you are writing an article, that point should come up there.
Correct.
See, I think if at all, even if this is a good study, for all these reasons, because the material methods and other things have not been laid out very clearly, it probably would not get accepted in any other journal because of that.
Yeah. I mean, that is the point. Yeah.
This is what we have to try and improve. I think it's a lesson for all of us.
Yeah. Let's look into the chat box before you actually put up the next slide, Pavan. Mahesh says it is physiological and pathological patterns of the bowel movement, I presume. Is that what you mean, Mahesh?
Yes, sir. The way the FT is taken up, yeah.
Okay. Nishant says, who did the ultrasound abdomen? Is it mentioned? No, it's not, because it is observer dependent and irritable bowel syndrome and other things. Yeah, that's a point. Then, they have mentioned about who did the PET CT, who read the PET CT, but they are not mentioned about the ultrasound. Vanilla brings up the point, chronic mesenteric ischemia. Yes, that's one of the differential diagnoses. Chronic abdominal pain is a huge umbrella of diagnosis, and so, yes, chronic mesenteric ischemia is one of them. Okay, Nishant says something about the patient's pain. It says in the results they have mentioned that chronic pain abdomen is for 6 months or more. Yeah, I mean, I see the point that the minimum they took into consideration was 4 months. But up front, they must define the cohort by mentioning it in the material methods. That was the point I was making. Okay, go on, Pavan.
Thanks. The first for this study is, as it is a relevant topic, and even though the impact factor is low, as it is our journal, which is published in our Indian Journal of Surgery, and it is a prospective study, and a reasonable exclusion criteria is there, as I mentioned earlier, and good physical examination and good description of protocol, and the PET CT is reporting is done by experienced radiologists. The against points of this study is that they not mention anything here about that definition of chronic pain, and the medical causes that were ruled by physician, how they ruled out, they are not mentioned in this study. And they are not mentioned about that fecal occult blood and endoscopy based on this should have been included actually. But they should not rule out the diabetic ketoacidosis, plumbism, and porphyria and their related tests. And as in India, the most common cause is some deworming. Cause of abdominal pain is worm infestations. So they're not mentioned about the deworming, and constipation do not find a mention. As a PET CT is a costly, it is an against for this study. And, coming to the results, actually, in the study, 30 patients are recruited. Out of this, the mean age of this patient is 33.3, and most of the patients are females. That is around that is 20 patients. Most of the patients, that is 70% of the patients having a pain duration of 4 to 8 months, and patients having chronic abdominal pain is more than 6 months is 60% of the patients. In all these patients, that ultrasound, abdomen, and CT scan were negative in all these patients. The most common cause of pains were umbilical and hypogastric region in 50% of the patients, and generalized abdominal pain in 30% of the patients. At this, the FDG, the table showing FDG PET findings that actually out of this, the definitive diagnosis is made in 6 individuals out of 30 patients, and the definitive diagnosis is not made in 18 individuals. It is not 25, actually 24 patients. The negative predictive value is the definitive diagnosis is not made in 18 patients, so that is 100%. The number of patients in whom the final diagnosis was made is through FDG PET is 6. The total patients, we know that 30. The yield of this study is 20, as it is low. Out of the 6 patients, 3 patients were diagnosed as tuberculosis, and one of the patient was started on ATT based treatment. That is the PET CT showing metabolically active subcentroaortocaval lymph nodes, and in whom there is a raised ESR with borderline Montauk's. And the patient was clinically diagnosed as extrapulmonary tuberculosis, and ATT is started, and pain is relieved, symptoms and all relieved at 3 months. And the diagnosis is made according to the index TB guidelines. If the clinical suspicion of tuberculosis is high, even though in absence of any microbial evidence, it is clinically diagnosed as tuberculosis. Coming to another patient, that the patient's normal ESR with the positive Montauk test came with chronic pain in the abdomen with the normal conventional imagings. The PET CT showing uptake, metabolically active uptake in the ileocecal area, and diagnostic laparoscopy showing that tuberculous abdomen. And third patient came with a chronic dull aching pain, and in whom that ESR is 26 with borderline Montauk's. Patient showing metabolically active mediastinal and abdominal lymph nodes. The bronchoscopy guided biopsy showing epithelioid granulomas. And one more patient having a diffused increased uptake of ascending and descending arch of aorta, suggesting of aortoarteritis, and having a high ESR, and the patient pain is relieved on treating with steroids. And one more patient having a infective lung lesions coincidentally, and the pain is relieved after treating with antibiotics. And one patient having intermittent pain in the right side abdomen for 9 months, and with a normal CT and ultrasound with the ESR is 24, and the PET CT showing metabolically active mesenteric lymph nodes in the terminal ileum and cecal area. Diagnostic laparoscopy showing inflamed appendix. After appendectomy, the pain got relieved. So they done in this study, they done a correlation between the longer duration of pain and the VAS score, and this 52% of the patients having score more than 4, having findings in the PET-CT, when compared with the VAS score less than 4 in 11.1% of the patients in whom p-value is 0.034. And coming to the duration of pain and the PET-CT findings, that is the 43% of the patients having showing PET-CT findings in whom the pain duration is more than 5 months, and 28.5% of the patients with pain is less than 5 months of duration. The p-value is less than 0.48. And there is a correlation between the raised ESR and the borderline or positive contacts in the findings in the CT. Out of 6 patients, 4% having raised ESR in whom the p-value is 0.28, as compared with the only 30% of the patient with normal ESR in whom p-value is less than 0.001. 83% of the patients with positive or borderline having some PET-CT findings, and 29.2% have the negative contacts having some PET-CT findings. P-value is 0.026. These are the findings FDG unrelated to pain abdomen. Out of this, the 6 patients in whom the increased FDG uptake in right iliac fossa, the bone marrow biopsy is done, but the biopsy is normal. Similarly, diffused increased uptake in sigmoid colon, sigmoidoscopy shows normal, and multiple metabolically active retroperitoneal and mesenteric lymph nodes, diagnostic laparoscopy is done, but it is normal, and subcentric hyperdense lesions in the right lobe of the thyroid, ultrasound guided cytology and right hemithyroidectomy showing some suspicious papillary carcinoma, and increased uptake in adenexa of uterine cavity, transvaginal ultrasound and pap smear done, the results are normal, and focal FDG uptake in left breast, lower outer quadrant, ultrasound guided cytology, it is a fibroadenoma, and multiple foci of uptake in the prostate with no nodules, digital rectal examination, rectal ultrasound showing normal. So, and the patient whom no diagnosis or no organic cause, that is 24 patients were referred for psychosomatic evaluation, and they are through telephonic communications for 3 months, and those patients, 14 patients are pain decreased, and the pain is like similar only in 9 patients, and 1 patient is lost in follow-up.
All right, before we go to the critique of the paper, all right, let us bring Madan in. He is a first year in Aster. Madan, what is your view of the way the results were presented? In fact, I mentioned it to Pavan in private during his preparation, but I didn't want him to change it so that our students will get an experience of how a results section or any paper in a journal club has to be presented. Madan, your critique of, I'm not talking about the paper itself, we'll come back to that, about the way the results were presented. Would you do it the same way or would you do it differently?
Sir, the positive predictive value so far.
I'm not talking about I'm not talking about the data or things, just the way you saw the wordings and tables and things on the slide and the way it was presented. Did it grab you? Let me ask you a blunt question. Did you find it interesting?
It was understandable for me.
It was understandable. Hari, would you say that?
No, sir. He could have put a pie chart as a chart type of thing to make it much clearer.
Sarah, what do you have to say?
So I would say the same only, sir. Yes, at least some.
Were you listening to him with attention? looking for the data that he was trying to give?
So actually,
It should be highlighted.
It should be highlighted. I read the paper, so
You
I
know,
knew
to
about
be
the
very
data.
honest, I'm sure you guys are very nice. I'm less nice, but no offense meant, Pavan. I'm sure all of us completely switched off. In a monotonous way, you're saying 82% of this, 23% of that. None of that is required. When you present a paper, results of a paper, you don't have to put so many words on the slide. Highlight the things which are positive, highlight the things which are negative. Nothing else is required. So instead of the 8 or 9 slides that you had for results section, you had 3 slides, and you completely read that whole table. Go back 1 slide. Yeah, you read this table. It serves no earthly purpose, Pavan. Understand that nobody reads papers, nobody listens to you. Okay, so what you have to do is put little summary of this table in a box on it. You can say that among the findings of PET CT, unrelated abdominal pain, there were X number of cases of some disease, one fibroadenoma, just highlights, or even included diseases from different systems. You know, there was a disease in the breast, a disease in the thyroid, a disease in the lung, or whatever. That is all that has to be done. Okay, I deliberately didn't want him to change it because I wanted people to know how to put the results and make it interesting to the audience. Go to the critique section. Now, can I invite Hari to critique the results section? What do you have to say?
Yes, sir. I think so. The results, like the pain and VAS, I can see that 50% is pain and VAS are matching. So like results are coming good. I think the values are honest. And against, if I think, one second. No, sir, nothing. I think
nothing else. Janani, we haven't heard your voice this evening. What have you to say?
Sir, in results, as you said, there are many percentage this, that, but there is no specific table mentioning the entire results. So it is very difficult to notify the numbers, sir.
All right. So you're saying the presentation of descriptive statistics is not good enough. That's what I'm trying to say. But what do you have to say about the data itself? They had correlated, for example, the Monto and something else with positivity in FDG PET. Is that a, what do you think about that kind of comparison?
Sir, it's like they're comparing only as only those tests with the FDG. There might be false positives like malignancy.
Would you give a lot of value to that because there are only 6 patients?
No, sir. No.
Yeah, there is. You have to take it with a pinch of salt. That is what. That is the kind of analysis that you have to do.
Yes,
all right. Now let's take some questions from the chat box. This is a question for Saurav. Dr. Ramakrishna asks, what is negative predictive value and what is the meaning of an NPV of 100%?
Sir, I don't remember actually, sir.
Okay, just give a broad meaning. You don't have to give me the formula for calculating the positive or negative predictive value. But what does it mean to you?
So it usually means that when we are conducting a test, what is the chances that
okay, you're finding, yeah, you don't know. Vanita.
Sir, probability of a screening test to detect true negative cases, sir.
Yeah. So 100% of NPV means what to you?
Sir, 100, even 10% of false negative cases also we should not expect, sir. Patient with a screening test, if it's 100%.
What does 100% NPV mean to you? In broad terms, as a surgeon, Ramakrishna sir, can you come in, please?
Hello, sir.
Yeah.
Yeah. What she was telling is almost nearing it. It is the capacity of the test to predict the negative point. That means how many of the total negatives were picked up in this particular test.
Correct.
If it has picked up all the 100 negatives, that means if the test comes negative, there is no chance that there is a
that is the word I was
result.
looking for.
Yeah,
Okay.
that is the main thing.
So when the test says it
so
is negative, when NPV is 100%, it means it is not there. The disease is not there.
Yeah, formula I was asking, it is the true negatives divided by total number of negatives.
Yeah. Okay. Okay, what else means patient and test negative normally doesn't have the disease? Correct. Okay, there's a problem in the test of significance used. Can you pick it up? Question from Dr. Ramakrishna again. So was it the number in the chi-square table?
Yes, sir. Somebody has already answered it.
Answered it, I didn't. Oh, 2 into table.
2 into
Okay,
2
okay. Oh,
table. They have
correct.
very small numbers like 0, 3, 4 like that, and they have used chi-square test. Actually, Fisher test should have been better.
Oh, correct. Vanitha got it right. Very good, very good. But believe me, I didn't read it. Okay. And Vinila talks about consort. Yeah, you mean they didn't give a consort diagram? Is that what you mean, Vinila?
Yes, sir. Yes, sir.
Yeah. Okay. All right. So, I think the main critique in this paper is about the methodology and the way they claim they ruled out medical causes. Put up our critique, Pavan.
So there is one more thing, sir.
Hello, sir. Yeah.
Hello. There they have mentioned actually the result. They should mention the total number. They have only mentioned the percentages here. That is one problem. In the result, when we are writing a paper, we must always give the number, and in the bracket,
and then brackets give the correct.
Give the percentage. That is one thing. Second point is here they have mentioned in the females are likely to score the pain higher.
Yeah.
Means for the same intensity of pain, a male may say it is 3, a female can say it is 5, something like that. That's what they mean. They have mentioned it actually here. And they have used VAS as one of the criteria to say the correlation between the VAS score and FDG finding.
Yeah.
When it is a subjective like female giving more score than males, then you cannot correlate with that, because if it is a male patient, they will say 3. If it is a female patient, she will tell 5. Then they will say higher VAS score will have better correlation.
Yeah, I agree, but I totally agree with that. But I put it under the interesting correlation of pain with VAS score purely for discussion, because I don't think you can correlate any positive or negative findings other than post-operative pain, okay, for the intensity of VAS score. That's the point I was trying to make. But they have pushed it as one of the first time that I have seen in a paper where they have correlated it. Yes, I equally agree that it could have come on the other side also to say they should not have done it. I agree with that. But I had not even thought that somebody would correlate a VAS score with a finding in an investigation. But this is the first time I'm seeing it. That's why I put it there. And again, on the other side, they have correlated ESR and Monto, which are very non-specific. You know, as Ramakrishna sir rightly pointed out, you could say VAS also is like that. But to me, ESR and Monto are even more non-specific than somebody's VAS score. And that's why I put it in the against column. And when you're comparing things like this, statistics may give you some significance, but its clinical significance has to be questioned. Your comment, sir. Nuli, sir, what do you say about
that? Sir, overall, I read this paper. Okay, I am as a practicing surgeon about this chronic pain abdomen. A lot of patients we get, sir. Okay. And routine investigations we do, but this costly investigation, what they were asking, I talked to the AIMS people after reading this paper, sir. Hello?
Yeah,
am I audible, sir?
Yes, you are.
Okay.
Yeah.
So this investigation is paid by the institute, sir, not by the patient. That is the first thing I wanted to tell you. I verified it with them.
Yeah.
Second thing is routinely they are not doing this. Because what I mean to say is patients more than 3 months, repeatedly they come to our OPD. We have given so many treatment. They are not happy. They are not at all happy. In spite of all the investigations, ultimately they just to search for a diagnosis, they made it.
Yeah.
But at the end of the day, what they got it, look at the diagnosis. When you look at the diagnosis, even we are not happy, sir. For example, CT wise also, to diagnose a tuberculosis or a very small lesion of a malignancy and then to put them for treatment also is very difficult.
Right.
Somehow what we got after all this investigation, somehow I am disappointed. Sorry to say, because the sample size is very less, and what we got at the end of the day, nothing. Because when we were students, you might remember, sir, when such patients used to come with 6 months of pain, straight away we used to put them on like therapeutic anti-tuberculosis line of treatment.
Yes.
That's what they are doing here also. And now that is not allowed unless we diagnose it. But somehow looking at this, what they got at the end of this one, I am not happy, sir.
Right.
I don't know how all seniors agree with that.
Ravi, I mean, I agree with that, sir. Ravi, do you have specific comments about statistics being significant and our drawing inferences from non-specific parameters like ASR and Monto?
Sir, I think ASR and Monto are, because in India almost everybody would have, had exposure to Monto. Using that as a parameter probably, is probably not appropriate, I think.
Right. That's, yeah. Ramakrishna, would you agree?
Yeah, no, the idea here in this study, we can take anything, sir, just they are trying to prove it, whether it is correlating well or not.
Yeah.
So taking it, especially Mantos, as Dr. Ravishankar said, it is okay. But ESR, when it is raised, it is non-specific. We don't know what is the cause. They are trying to find out the cause through this test. So there is nothing wrong in taking it for study purpose.
Okay.
But using as a diagnostic purpose, then it becomes problem.
Right.
And regarding what Dr. Nooli was telling, whatever he said, everything is correct as when you are thinking of clinical practice. But when it comes to study, I think they should mention everything. After he called, he said it is paid by the institute. That is a different story. Everybody will not call AIMS.
Yeah.
So what we will infer, who has paid? Once they say we can imagine that patient has paid, then it becomes unethical.
Right.
Because it is not supported by evidence. Right. So that's all those things must be mentioned when we are discuss about a paper.
Yeah.
So how we should write a better paper? That is the main concentration rather than these things.
Yes,
Sir,
yes,
Doctor, one more comment.
Okay, go on, Ravi. Go on, Ravi.
Sir, my basic major problem with the paper is that having set out all the parameters, they have not commented whether any of these patients had chronic constipation or chronic diarrhea, which itself could cause pain.
Correct.
And if that has been treated, and how many of them persisted with the pain. So that I think is a major drawback in the because many of the, at least in pediatric population, there is significant portion of them with abdominal pain who only have chronic constipation, and the mother thinks that the patient, the boy is okay.
But this excludes pediatrics, so we'll leave it out of the discussion. Niranjan, your comments?
Only problem with including Monto, they have included positive Monto in cases such as chronic appendicitis also, and also aortoarteritis. So just for statistical significance, including positive Monto in those patients, I feel it is wrong. It should not be compared. That is one thing. Second thing, they have not mentioned what has happened to all those patients, which is quite a significant number, where their pain persisted even after psychosomatic consultation.
Yeah, correct. I thought the same, and I think they should have been offered diagnostic laparoscopy.
Yes, yes.
When the pain persisted and PET CT was negative, for them to really know what the cause is before sending him to a psychiatrist, I think the study should have naturally progressed to a diagnostic laparoscopy, particularly because the patient is not going to pay for it, in AIMS. So that's something that they could have considered. Now, this is a question for Pavan. Dr. Srikanth asks, what is index TB guidelines? Pavan.
Category 1 and category 2. And
what is the index TB guidelines? What is it?
How that
did you read the index TB guidelines?
Sir, I saw it, sir.
Where did you see it?
In the you downloaded it also, sir.
You downloaded it. Okay. So who put it out? Just you don't have to worry about all the details in the guidelines. Who put it out?
Sir?
Who were the publishers of these guidelines?
Ministry.
RNTCP, sir.
AIMS.
Yes, this is the Ministry of Health guidelines. Okay, and they have put it out, and they mention, and I think I have an axe to grind about it. They say that you start giving anti-tuberculosis treatment on the basis of clinical grounds. And they talk about negative microbiological studies, but they do not mention histology. Even though you may not be able to show microbiologically, even with these RT-PCRs and things like this, we still have to go by some kind of tissue diagnosis before you commit somebody to 6 months of anti-tuberculosis treatment. That has been the consensus over the last few years, but this particular Ministry of Health guidelines, it gives it a lot of legitimacy, says that you can give empirical anti-tuberculosis treatment. Comments from other seniors, please.
Sir, I listened to the gentleman who came from the National Tuberculosis Institute.
Yeah.
They are extremely clear. There is no question of starting anybody on empirical treatment. Yeah. There has to be a minimum of, as you said, tissue diagnosis preferable. Otherwise, the gene expert and such things have to be consulted before. Nobody should be started on empirical treatment.
So in the country, there is a debate about this. Please remember.
So why did these people start the anti-tuberculosis treatment based on ESR and Monto?
The main authors of that guideline, Srikanth, are from AIMS. They are from
No. This paper I'm asking, when their anti-tuberculosis treatment should not be started without histological diagnosis. In this paper,
that is what I'm answering, Srikanth. Listen to me. There is a debate and a difference of opinion in the country. People from NTI say you should have tissue diagnosis or gene expert diagnosis, RT-PCR or whatever, microbiological evidence. Yes. Whereas AIMS people say you can still give it.
Oh.
All right. And this paper is from AIMS. It's their own medical people. And that is why they have started. And there is a debate on this. I wanted to impress upon our students here that there is still a debate on the issue. That's all. And such debates will go on in life. So they must understand that everything that somebody says, others need not agree. Okay. Good, yes. Even though there is a general agreement that you do not start anybody on anti-TB without a tissue diagnosis.
Sir, but I would go more with the NTI guidelines because one, it does give legitimacy to tissue diagnosis, and second, it prevents people from starting anti-tuberculosis treatment willy-nilly and miss many lymphomas, ovarian cancers and such like.
Totally agree. Go on, Pavan. Yeah, go on.
Sorry. And also, it was not very difficult to get a tissue diagnosis in those two cases.
Yeah.
Where they had pelvic tuberculosis, where they suspected pelvic tuberculosis. They could have gotten it through diagnostic laparoscopy.
That's right. They have not mentioned diagnostic laparoscopy at all here, if you see in the whole paper, which is surprising. Yeah. Go on. Go on, Pavan. Yeah.
Yes, sir. The force for the study is, as it is an appropriate, having appropriate statistics.
It's all done. Next, go to the next slide. It's already discussed. Go to the next slide. Yeah.
Discussion regarding this.
Go on.
Yes. There is a raised ESR findings. Patients, those having raised ESR findings, having some findings in the PET-CT when compared with the negative PET-CT findings in 66% of the.
Don't read the slide, Pavan. Okay. In the first place, you should have put, as I told you earlier, just little points. At least now, try and get the habit of giving a summary of what you read from the paper. Yeah.
Yes.
I have confused you and made you nervous. That was not the idea. Go on. What did the Lenson study say to you? Don't read the paper. What did it say in your mind? What have you thought about what Lenson paper said?
Sir, Lanson paper say they done that PET CT scan in elderly individuals having prospective study showing more findings in the PET CT, and retrospective study also showing more findings, sir, having some diagnostic clues, sir.
Yeah, obviously that paper had two components, one prospective and one retrospective. And the retrospective study also showed a good number of people with positive PET CTs. Go on, next one, next slide. Skip this slide. We have discussed this. Skip this slide. We have already discussed about Monto and this. Yeah.
Yes,
skip this slide also. Yeah.
The strength of this studies.
Yeah, according to them.
Yes,
yeah.
sir. This is the first study having some correlation between the PET, undiagnosed abdominal pain with the PET CT, but the yield of the study is low. Those patients, out of 30 patients, 6 patients are diagnosed with the PET CT, and they are not done any diagnostic laparoscopy and not mentioned it, and those having some diagnosed abdominal pains and all, even though it is a gold standard investigation.
So they claim that, you know, that the first to do this. Would you give them marks for it? Would you think it's a great thing that they have done by being the first to use PET CT for abdominal pain? Yes or no?
Sir?
Would you applaud them? Would you say they've done a great thing by being the first to do a study with PET CT in abdominal pain?
Yes, sir.
You would? Yeah, I wouldn't anyway. That's a contentious issue. And the yield is 20%. Is it good or bad?
It's bad, sir.
Bad. Okay, next slide. Okay.
Actually, they compared that pain scale with the severity of the pain scale, and but the VAS score, which is a subjective finding, so it is not assessing the.
All right, we have discussed it already. Do you understand that?
Yes, sir.
We have already discussed the issue. Go to the next slide. Okay, put up the critique. We've discussed most of it. Yeah. So in terms of writing a paper, we have mentioned that it mentions the limitations of the study. It's good to always critique yourself in the paper itself. And there is the discussion, a reasonably good mechanism of abdominal pain. For youngsters who are reading the discussion in this paper, they'll know what visceral pain is. And as Ravi had mentioned earlier, and we've been mentioning throughout the critique, there's no mention of constipation and IBS at all. It should figure prominently in any discussion or any paper on abdominal pain. Low yield cannot change our practice based on this. And they have very little collateral reading. You know, I actually looked at papers on chronic abdominal pain and the approach to chronic abdominal pain. There are hundreds of papers. And in the discussion part where they should have discussed those papers, there is very little collateral reading that I could find. Any comments from the seniors here, please, sir, about this critique?
I think the main point to be taken home is that in a country like India, where, you know, I think as such, as we know, PET CT is being misused as a diagnostic tool. This definitely should not be prescribed, because it will open a Pandora's box, not only in terms of usage of PET CT unnecessarily, but then follow-up of these PET CT and going on a leather hunt. Yeah. So I think we should, you know, I think it should be very, very selective in terms of usage of PET CT as a diagnostic tool in chronic abdominal pain.
As you said, 60% of the patients coming to G or IBS.
Yeah.
We should give it an empirical treatment of IBS before going for further costly investigations or diagnostic laparoscopy.
If they have no danger symptoms, what are the danger symptoms, Janani, that you would ask in an outpatient clinic?
Sir, persistent, sir, with regard to pain abdomen, no, sir?
Danger symptoms with GI disease.
GI disease.
Yes, sir. Sir, persistent pain abdomen along with vomitings, multiple vomitings,
Okay.
mostly bilious vomiting.
Yeah.
And when
Okay,
pain
vomiting
is
is one. It actually comes low down on the list. But what are the other danger symptoms? Please, I want the students to really reel it off without batting an eyelid. Go on.
Sir, vomiting, then distension of abdomen, sir, abdominal distension. Then,
IBS, a lot of people have distension abdomen.
Yes.
That's one of the commonest symptoms. It's not a danger symptom. Okay,
Okay, sir.
we have gone on for an hour. Constipation is constipating IBS. It's not a danger symptom. Let me finish it because we have crossed 1 hour. All right, please, all the students, and I ask this of every patient who comes to my clinic with any abdominal symptom. Danger symptoms: weight loss, dysphagia, melena, rectal bleeding. Okay, remember this: weight loss, melena, rectal bleeding, dysphagia, particularly for solids. These are the danger symptoms. If any of
asthenia and anorexia also, sir.
Yeah, anorexia and yeah. Okay, so
and in educated people, recent change in a otherwise normal habit. Yeah.
Okay, so have this as your guideline. And if people don't have these danger symptoms, you know, all the things that you said, vomiting, it can be functional vomiting. Distension is very common in IBS. Chronic abdominal pain is what they come with. You know, constipation is what they come with. But I agree, recent change in bowel habit is an important thing. So please ask these 5 or 6 simple questions. If you don't have it, then there's no need to worry about it. Before we close, Pavan, you have done the collateral reading on investigation of chronic abdominal pain. Quickly go through that, please. Quickly go through that. We don't have too much time. Go on. Next slide. Go on. Quickly go through this. Don't read the slides.
Okay, sir.
Yeah.
We know that chronic abdominal pain, which is recurrent and which affects the daily activities and over a period of at least 3 months. The etiology may be organic or functional causes. These are the organic causes, and the functional causes means which is non-structural and functional causes, which can be Rome's diagnostic criteria, and these are the investigations routinely we have doing in a patient came with abdominal pain.
And go back one slide. Go back one. That is very. This slide is something you have to spend time on. Please go ahead.
Yes, sir. And ultrasound abdomen, we are doing after doing ultrasound abdomen. Stool examination we have to do in the case of GIT symptoms, like occult stools and all, to rule out some malignant conditions, and CECT and upper GI endoscopy or colonoscopy to rule out any upper GI pathologies, and MRCP. Finally, we done diagnostic laparoscopy if needed.
Well, just before that, in this particular paper, they don't mention PET CT at all. But yes, I think we should have in mind PET CT before we go in for diagnostic laparoscopy. Next one, please.
That some guidelines showing that we have to include some blood tests like tissue transglutaminases and duodenal biopsies in the case of some celiac diseases.
Yeah, very uncommon in our country. Yeah, next slide.
And non-invasive biomarkers like C-creatine protein and fecal calproteinin in the case of which is significant in ulcerative colitis and having risk of less than 1%. And the chronic abdominal pain should be evaluated for colorectal cancers and defecatory disorders. In the case of defecatory disorder, which is an discoordination present between the abdominal wall and sphincter muscles, and to diagnose DD, that means defecatory disorders, we have to do
pelvic manometry. Yeah. Okay. Next slide.
Rectal manometry. And the cause of one, we have to remember that chronic abdominal pain may be due to some adhesions who undergone some previous surgeries and all. And rare causes of chronic abdominal pain like porphyrias and hereditary angioedemas and endometriosis. The endometriosis and conditions can be diagnosed through laparoscopy guided biopsy.
Yeah. Okay. Thank you. And before we close, Niranjan, any other remarks that you want to make?
Nothing, sir.
Nothing. Nuli, sir.
Sir, just a point. While discussing with them again, the patients were given a choice in the sense invasive, sir, diagnostic laparoscopy. And these people were wanted to study this as such. They were interested in this investigation, that too when it is paid by the institute.
Yeah.
Okay. So diagnostic laparoscopy, a choice was given to these patients, sir. But since it is invasive, some patients were not reluctant to undergo that procedure. This procedure, only that point I wanted to make.
All right. Okay.
Otherwise, paper was good.
No. What is the take-home message? In a affordable patient, when all the non-invasive tests are negative, we should be asked for PET-CT before diagnostic lab now.
Yeah. What is the vote on that? Ravi?
In an affordable patient.
Yeah. Ravi, what would you say? Has he left? He might have left. Ramakrishna? Affordable, available, would you do a PET-CT before offering diagnostic laparoscopy?
Not based on this particular paper, sir. And I think we have missed that last part, the conclusion part we have not discussed.
Yeah.
They have mentioned one line without data. You always used to tell, no?
Yeah.
Any abnormal foci or patterns of uptake found in PET-CT scan were correlated with other investigation. That's what they have mentioned.
Yeah.
But there is no data.
No data on that. Yeah. I agree.
No data on this particular conclusion. And based on this paper, we cannot recommend.
Yeah, that's what I was trying to say. I totally agree with Ramakrishna on this, Shrikant, that based on the data given in this paper, I would still go for diagnostic laparoscopy in preference to
before diagnostic lab.
You see, if I'm not going to believe the results that come out of PET-CT, why would, if PET-CT stops me from doing a diagnostic laparoscopy, I would ask for it. But with the data given here and in other papers, particularly when I have neoplasm in mind, when there is such an overlap between inflammatory and neoplastic disease in PET-CT, I would much prefer to have, even though it's invasive, I would prefer to do a diagnostic laparoscopy. That is the take-home message that I took from this paper for myself.
Tissue diagnosis is possible, sir, during laparoscopy.
That's another advantage, obviously, of course.
Sir, okay. I think you asked me the question. This one was muted at that time.
Okay.
Sir, as I agree with you and Ramakrishna, I think based on this paper and considering the wider ramifications of recommending something like this, which the GPs will lap it up, and then I think there will be too many diagnostic PET-CTs that be done. I wouldn't recommend it as a standard. I think mainly re-evaluating patients in the clinic on a regular basis, and only if symptoms are persistent or anything new has happened, then diagnostic laparoscopy may be first.
Okay, I think we will close the session here. Thank you very much for your very active participation.
Thank you, sir. Thank you.
All right. Good night.
Thank you, sir. Thank you.
Good night.